Absolutely. And so again, really, really excited for this combination. And so this was a phase 1, phase 2 study led by Courtney DiNardo and MD Anderson. And we were evaluating both the safety as well as the efficacy of this oral triplet regimen, combining the oral decitabine, venetoclax, and either ivosidenib or enasidenib for patients that had IDH1 or IDH2 mutations. And what we did in this trial is patients that were eligible were adults that were either had relapsed or refractory disease, or they could have newly diagnosed disease if they were deemed ineligible for intensive chemotherapy. And they received a treatment schedule of 5 days of the oral decitabine. The IDH inhibitor was given continuously, and then they received 14 days of venetoclax. The main outcomes we were looking for, again, were safety, and then we were looking at the composite complete remission rate to see if that was different compared to the historic kind of standard of care regimens. And then we were also looking at overall survival, duration of remission, and those types of things as well. And so at time of kind of the data cutoff for this poster, this was when our newly diagnosed cohort had completed enrollment. So it was an interim analysis at that point in time. And we had enrolled a total of 105 patients. And so that was 62 patients with newly diagnosed disease and 43 patients with relapsed refractory disease. Things to note about this population, it is a little bit different from the VIALE-A and the Agile cohorts because we allowed patients that had received prior HMA therapy, venetoclax therapy, and prior IDH inhibitor therapy. So people that had MDS got these treatments and then transformed to AML, they were still eligible in our newly diagnosed cohort, but they are particularly high risk because they were a treated secondary AML before. And kind of as expected, older age group, median age 71, again, kind of high risk disease. So 82% of patients had adverse risk disease by the ELN. There was 10% of patients that had TP53 mutant disease in our newly diagnosed cohort. A third of patients in the relapsed refractory had TP53 mutations as well. When we go and look at the actual outcomes for our patients, in our newly diagnosed cohort, we saw a composite complete remission rate of 86% in the ivosidenib arm and 91% in the enasidenib arm. And so really, really good results compared to some of our historic controls, up in the 90% range. In a relapsed refractory cohort, we were seeing composite complete remission rates in the 50s and 60s. So much higher than we would typically expect in this population, where we expect more of a remission rate around 20 to 30%. And notably, the early mortality was quite low. So there was only one patient with 30-day mortality in the newly diagnosed cohort, and then one patient with early mortality in the relapsed refractory cohort. When we look at our overall survival, we separated out some of those high-risk patients who had received prior venetoclax, ivosidenib, or HMA therapy. And if we look at our newly diagnosed cohort that are treatment naive, we still haven't reached the median overall survival. And at 2 years in the IDH1 cohort, we have a 90% overall survival. So these patients are doing really, really well and living a long time on therapy. Similarly, in IDH2 cohort, our 2-year overall survival is 73%. So again, really impressive results. In our treated secondary AML group, kind of a higher risk cohort, the median overall survival was 10.8 months for IDH1 and 6.5 months for IDH2. And so while they might not seem as impressive, when you look at how these patients usually do, usually their median overall survival is among the 2 to 4 month range. So they're doing quite well. In our relapsed refractory population, these patients had a median overall survival of about a year in both cohorts. So again, higher than we would typically expect and are doing quite well. When we look at safety and tolerability of the regimens, really we're not seeing much differences for patients that were treated with just HMA and venetoclax alone. We're seeing about a third of patients experiencing grade 3 infections, nothing that we wouldn't expect. But otherwise, we're not seeing a lot of other toxicity. Low levels of QTc prolongation is expected. Hyperbilirubinemia with the enasidenib is expected, but nothing that wasn't manageable. No, high rates of differentiation syndrome or anything like that. And so overall, the regimen was really well tolerated, and we were just very excited by seeing these, 90% composite complete remission rates in the newly diagnosed patients, and what looks to potentially be, really impressive survival rates.